Good day, one and all. Today's topic for discussion is hepatitis. Hepatitis is defined by the inflammation of liver and characterized by the presence of inflammatory cells in the tissue of the organ. It has two phases, acute and chronic. Acute being less than 6 months and chronic being more than 6 months. It can be classified as viral and non-viral hepatitis. Viral hepatitis can be hepatitis A, B, C, D, E, and G. Non-viral hepatitis can be caused by autoimmune or alcoholic, metabolic, or toxic and drug induced. Pathological changes seen in hepatitis. In acute hepatitis, you can see ballooning degeneration, concealment bodies, disruption of lobular architecture, interface hepatitis, and bridging necrosis. In chronic hepatitis, we can see groundless hepatocytes, bridging fibrosis, cirrhosis, and can see most commonly mononuclear macrophage aggregates. Coming to viral hepatitis. All the viruses causing hepatitis belong to RNA virus except hepatitis B, which is a DNA virus. Hepatitis A belongs to the family Picorna, hepatitis B belongs to Hepatna virus, and hepatitis C belongs to flavivirus, hepatitis D belongs to Delta virus, hepatitis E belongs to Hepivirus. Hepatitis A and E are transmitted through fecal-oral route. The hepatitis A takes 2 to 6 weeks for incubation and hepatitis E takes 4 to 5 weeks. Hepatitis B, C, and D are transmitted parenterally, vertically, and sexually. They take about 2 to 26 weeks for incubation. Hepatitis B and C are carcinogenic, C being the most chronic. Hepatitis E has maximum mortality in pregnancy. The most common worldwide hepatitis in adults is hepatitis E and in children is hepatitis A. Hepatitis A virus is a single-stranded RNA virus belonging to the family Picornaviridae. It's non-enveloped, heat-sensitive pathogenesis. It enters through the mouth through ingestion. It multiplies in the oropharynx and intestinal epithelial cells. Through lymphatics, it enters the bloodstream and reaches liver. Virus targets the liver where it likes to replicate. Signs and symptoms of hepatitis A. It causes nausea, vomiting, fatigue, dark urine, digestion disorders, jaundice, fever, pain in the right upper quadrant of the abdomen. Clinically, jaundice is noticed. ALT and AST levels will be more than 1000. Anti-HAV IgM bodies would disappear in blood in 12 weeks and clinically in 8 weeks. Anti-HAV IgG would show that the patient has recovered. Acute relapsing hepatitis occurs in every 1 lakh patients. Encephalopathy with or without coagulopathy within 7 days of onset of the symptoms. It's very rare and is asymptomatic, and vaccine is present. Hepatitis A is usually self-limiting. Management would involve IV fluids of 10% dextrose, about 3 pence, that is 150 grams. Prevention would involve good personal hygiene, leading a healthy lifestyle, taking full rest, eating proper nutritious food, drinking lot of water. Vaccination is available. Havrex, which is about 3 doses at 0, 6 and 12 months. About 1 ml IM dose is given. Pre-exposure vaccine is given 2 weeks prior to the travel and post-exposure before 2 weeks of exposure. Hepatitis E virus belongs to the family Hepiviridae under calcivirus. It's a single-stranded RNA virus. It's non-enveloped. It has 4 genotypes and mode of transmission is through fecal-oral. Clinical picture is almost same as hepatitis A. Difference between hepatitis A and hepatitis E. Hepatitis E has cholestatic phase and hepatitis A has relapsing phase. Vaccine is not available for hepatitis E virus. Risk of fulminant hepatitis in hepatitis A is about 1 to 2% and in pregnancy it's about 20%. Anti-HEV IgM returns to normal by 16 weeks and clinical recovery occurs in 8 weeks. Hepatitis B virus is a DNA virus belonging to the family Hepatinovirus. It's partially double-stranded. If it's complete, it is called a negative strand. If it is incomplete, it is called as a positive strand. A 42 nanometer particle identified by electron microscopy. The complete infective virion of hepatitis B virus is the Dane particle. The symptoms of hepatitis B are jaundice, itching, flu-like prodromal symptoms, fatigue, fever, pale or clay-colored stools and dark urine, abdominal pain, nausea and vomiting. Hepatitis B is transmitted through direct blood-to-blood contact, vertical transmission from mother to child during birth, unhygienic tattoo, piercings, barbers, scarification, circumcision practices, sharing of the needles and household contact, sharing of hygienic equipments like razors, toothbrushes, earrings, etc. Unsterile healthcare practices, sexual transmission. There is a risk during any type of sexual contact. The replication cycle of hepatitis B virus involves attachment to the cell, endocytosis, fusion of the viral envelope at the plasma membrane, release of the viral nucleocapsid containing the relaxed circular partial double-stranded DNA of nucleocapsid, transport along the microtubules and formation of covalently closed circular DNA, transcription, translation, reverse transcription, re-imported into the nucleus or enveloped for secretion. Serological markers of hepatitis B. HBsAg is the antigen found on the surface of hepatitis B virus, indicates hepatitis B infection. Anti-HBs, antibody to HBsAg, indicates the immunity to hepatitis B due to vaccination or recovery from the infection. HBcAg is antigen associated with core of HBV. Anti-HBc is antibody to hepatitis B core antigen. IgM is acute or recent infection. IgG, prior exposure or chronic infection. IgM anti-HBc core may be the sole positive marker of infection during a window period. HBeAg is secreted by infected hepatocyte into the circulation, not part of the mature HB virus virion, indicates active viral replication and therefore high transmissibility and poorer prognosis. Anti-HBe is antibody to HBe antigen, indicates low transmissibility. The serological patterns of hepatitis B infection. Acute hepatitis B with high infectivity would have HBsAg positive, HBeAg positive, and IgM anti-HBc. In window period, anti-HBe would be positive and IgM anti-HBc. Chronic hepatitis B virus with high infectivity would have HBsAg positive, HBeAg positive with IgG anti-HBc. Chronic hepatitis B virus with low infectivity would have HBsAg positive and anti-HBe positive with IgG anti-HBc. In recovery period, anti-HBs would be positive, anti-HBe would be positive with IgG anti-HBc. If immunized, would have anti-HBsA positive. Treatment of hepatitis B would involve interferons, lamivudins, adenovir, pegylated interferon, entecavir, telbibudin, tenofovir. Acute hepatitis B infection can be converted into chronic hepatitis B infection in 3 to 5% of adult acquired infections and 95% of infant acquired infections. Chronic hepatitis would be asymptomatic, having intermittent jaundice. ALT levels would be more than AST levels. Extrahepatics would involve polyarthritis nodosa in about 30% of the patients, membranous nephropathy, and involving small joint arthritis. Chronic hepatitis in 12 to 25% in 5 years could undergo liver cirrhosis causing and liver cirrhosis in about 6 to 15% in 5 years could cause hepatocellular carcinoma, and in 20 to 23% in 5 years could cause liver failure. Chronic hepatitis B can be diagnosed if HBeAg is positive, HBV DNA is more than 20,000, it's high infectivity. If HBeAg is negative and HBV DNA is less than 2000, it's in carrier state. If HBV DNA is more than 2000, it's high infectivity. FibroScan can diagnose if it's serotic or non-serotic. If non-serotic and ALT is more than 2 times upper limit, or if ALT less than 2 times, there's no requirement for any treatment. The diagnostic criteria for chronic hepatitis B virus, HBsAg positive after 6 months, serum HBV DNA more than 10 to the power of 5 international units per ml, persistent or intermittent elevation of ALT, AST levels, liver biopsy showing chronic hepatitis, or phases of chronic hepatitis B is immune tolerance. When HBV DNA is more, ALT levels are normal and no inflammation is seen. Immune clearance, if HBV DNA is low, ALT levels are increased and inflammation is present. Inactive or carrier state, if HBV DNA is decreased, ALT levels are normal and no inflammation is seen. Reactivation, if acute hepatitis B, if HBsAg is positive with ALT elevated, HBeAg negative, HBV DNA increased. Treatment for Chronic hepatitis B is 7 drugs have been approved up till date. Injectable interferon alpha, pegylated interferon, lamivudine, adenovirus, entecavir, telbivudine, tenofovir. Prophylaxis for hepatitis B is hepatitis B immunoglobulin recombinant vaccine. Vaccination as per the National Immunization Schedule by Government of India is given at birth, at 6 weeks, 10 weeks and 14 weeks. The dosing schedule in adults is 0, 1 to 2 months and 4 to 6 months. If patient falls behind on hepatitis B vaccination schedule, even if a year or more, the vaccination is continued from where the patient has left off. There is no need to restart again. Hepatitis C is a positive sense single-stranded RNA belonging to Flaviviridae family. Punjab in India has the highest prevalence. Genotype 3 is the commonest genotype in India, most prone for cirrhosis. Genotype 1 is commonest in worldwide. There is no vaccine available. The steps of replication in hepatitis C virus is attachment, entry, uncoating, translation, replication, assembly and maturation, and release. Hepatitis C is transmitted mostly due to injection drug use, followed by sexual, transfusion, and hemodialysis or healthcare work or perinatal. The outcomes of hepatitis C virus hepatitis. After the hepatitis C virus infection, it could follow a subclinical course in 75% of the patients or acute hepatitis in 25% of the patients. They both would go into persistent infection in 85 to 100% patients and form chronic hepatitis in 50 to 70% of the patients. Liver cirrhosis is in 12 to 25% after 20 years, and about 1 to 5% can have liver cancer. Acute hepatitis can very rarely form fulminant hepatitis. Extrahepatic problems is seen in 7% of the patients, that is arthritis, skin problems, glomerular nephritis, cryoglobulinemia. Serology of hepatitis C. In acute hepatitis, anti-HCV is positive and HCV RNA is positive. In 6 months, 85% of HCV RNA positive, then it's chronic hepatitis. In 15% of the patients, HCV RNA would be undetectable, showing they have recovered. In chronic, ALT, AST enzymes have no value. Treatment of hepatitis C virus according to the genotype 1 and 4 would be treated for a duration of 48 weeks, and genotype 2 and 3 would be treated for 24 weeks. WHO recommends treatment to all individuals diagnosed with hepatitis C infection who are 12 or more years of age, irrespective of disease stage. WHO recommends the use of pangenotypic DAA regimens for the treatment of the persons with chronic HCV infection aged 18 or above. Pangenotypic drugs would be NS5A inhibitor with NS5B inhibitor for 12 weeks. Example, Velpatasvir 100 mg daily with Sobofovir 400 mg daily. If decompensated cirrhosis, adding ribavirin would show improvement. Hepatitis D can be contracted in 2 ways, co-infection or superinfection. Co-infection is getting hepatitis B and D simultaneously. Likelihood of it becoming chronic is very unlikely. There is no risk of cirrhosis, risk of fulminant hepatitis is about 20%. Superinfection is being chronically infected with hepatitis B and then contracting hepatitis D virus. There is likelihood of becoming chronic about 70 to 90%. There's risk of cirrhosis. Anti-LKM3 antibodies are found. Hepatitis G or GB virus C is